I still would like to say a couple of words about Jonathan. So Jonathan is, as he said, he's a director of the biomedical ethics unit, but he's also a member of social studies of medicine. He's a very successful bioethicist. He's on the, he chairs the Committee on Ethics and Public Policy at the International Society of Stem Cell Research. He's the author of a book on translational research, ethics and translational research, called Lost in Translation. Not very original, that title, come on. And I know there are at least 3 or 4 other papers with that title. Anyway, but it's a very good book, in spite of the... And so we share an interest in drugs, clinical trial, and also in what he calls the science of science. I would just call it playing with numbers to find out what's happening in science. And so please, the floor is yours. Well, thanks.
Great. Well, thank you so much for the invitation. It's really, it's an honor to be here and to contribute. I am speaking with a lot of humility here. For me, this is virtually terra incognita. I do not work so much in surgery. I'm also mostly in a room of historians or people with a historical inclination. I'm not a historian, so much of what I say may be historically somewhat underinformed. There are a couple reasons why I think it's not entirely unreasonable for me to be presenting to you today. The first is that many of the, so as my biography noted, I do a lot of work looking at novel technology development, and much of my work has centered on stem cell and gene transfer development. Many biologics that are being developed require surgical delivery, and so, and many of the surgical delivery strategies are themselves fairly novel, and so certainly the kinds of things that I think about often involve novel surgical components, and so, you know, some of these issues in surgery are somewhat familiar to me. I guess the second reason why, you know, even though this is unfamiliar territory for me, I feel at least some, you know, have some standing here, is that I spend a lot of my time trying to think about medical innovation, and much of what I'm going to present to you is work that I've done trying to think about how one innovates in the context of developing novel interventions like drugs. If my theories are correct, if they are robust, they should in principle extend to surgery, and to me it's a really great opportunity to test the robustness of my understanding of innovation and medicine, and to try to find at least where the boundaries are, the limits are of the framework I'm going to present. So with those provisos, bearing them in mind, my talk is going to divide into 4 different sections. First, I want to introduce some of the kind of canonical ethical problems of medical innovation. Secondly, I want to describe how knowing something about the structural properties of medical innovation, well, first I want to describe what I think are some key structural properties of medical innovation, and then explain why understanding that structure can inform our thinking about how to resolve some of these key ethical questions that we encounter in medical innovation. And then I want to close by trying to extend the approach that I presented somewhat in the context of surgery to more kind of mainstream surgeries, and to think at least a little bit about some of the limits of the framework that I presented. Okay, so ethical problems in medical innovation. So every drug, every medical innovation, every surgery, device, biologic begins its life as a poison. It begins its life as mayhem. Unlike in criminal law, where the criminal is presumed to be innocent until proven guilty, in medicine, it's the exact opposite. You're guilty until you are proven innocent. And so the task for medical innovation is to transform these potentially clinically useful interventions that are by default poisonous into validated interventions. Now, drugs cause between the 4th and 6th leading, or between the 4th and 6th leading cause of death in the United States, adverse drug reactions. And surgeries, by definition, when you slice into someone, you are harming them. So the warrant for undertaking these potentially harmful interventions is drawn from evidence that suggests that there is a therapeutic benefit to redeem that potential harm. Now, in surgery, something that is really distinctive is that one of the key motivators for development of rigorous evidence about the therapeutic value and utility of interventions is not present. So normally for drugs, devices, biologics, there is a regulatory authority that forbids a company from marketing its product until it has rigorously proven the safety and efficacy of a product. And that provides an incredibly strong financial incentive for companies to underwrite the kinds of rigorous randomized controlled trials that are necessary to warrant use of a potentially toxic intervention. In surgery, we don't have that presence of a regulatory authority. And partly as a result, there are a number of examples of surgeries that have been introduced into clinical practice lacking really rigorous evidence to establish their efficacy. And I'll give a couple examples, although this is not really a good example of something that was successfully translated, but it is an example of a surgical procedure, a complex surgical procedure, one that involved delivery of a biologic, that was on the basis of open label studies believed to be highly efficacious, highly durable responses, and that's namely the fetal tissue transplantation for the treatment of Parkinson's disease. And when it was put to randomized controlled trials in the late 1990s, in a sham comparator study, completely unexpectedly, the intervention failed to be vindicated. It didn't really have any advantage at all over sham comparators. And one of the interesting episodes in this, or aspects of this episode at least, is the fact that when patients received grafts, they encountered adverse events, graft-induced dyskinesias, that had never been encountered in open-label studies. Now, after those trials were published, researchers went back and performed blinded videography on some of the patients that had received fetal tissue grafts in open-label studies, and it turned out that those dyskinesias were present all along. They just hadn't actually been noticed in the open-label studies. So the randomized control trial made visible what had previously been present but invisible to the researchers conducting open-label studies. So a really notorious example of a surgery that could have easily been put into clinical practice but was caught by randomized control trials. Of course, there's also the famous example of the arthroscopic surgery of the knee for treatment of osteoarthritis. Again, an example of a sham comparator study that ended up showing no superiority of the surgical procedure for treatment of the condition. In fact, in 2014, there was an article published in the British Medical Journal that performed a systematic review of sham comparator studies in surgery, and what they showed was that 50% of the sham comparator studies failed to show superiority of the surgical procedure over the sham. So there's actually a major challenge in terms of surgeries being clinically vindicated. And what this tells us, this is true for drugs, but it's, I think, especially true for surgeries where there isn't this pressure from regulatory authorities, that our theories of disease causation are really fickle guides in terms of underwriting evidence for using surgical procedures in the clinic. And what's more, given the theory-ladenness of our inquiry and of our knowledge, it's key to design research in a way that prevents the observer from really knowing allocation, from knowing which procedures an individual has been allocated to, so that you can really be confident that there is an unbiased estimate of the clinical value of an intervention. Okay, great. So we need really good evidence. It's hard to collect it in the context of surgery. We especially need it in surgery where there is much less regulatory pressure. Of course, trying to develop this surgery is incredibly challenging for a number of reasons, not the least of which are the ethical problems of dealing with patients who, after all, have a moral status. They have a right to having their interests protected. So one of the big questions that is recurrent in clinical development is the question of when to randomize. When is it ethical to randomly allocate a patient to a surgery or a drug versus to allocate them to a standard of care? Another really key ethical challenge is a question about the aggressiveness of development. So if you can think about this diagram I showed where you've got the skull and crossbones over here and the therapy, the question is how rapidly ought you to unfold a clinical development trajectory in order to reach that therapeutic end? Of course, you can do it very, very rapidly in principle, but you may end up cracking a few skulls in the process and killing a couple patients. On the other hand, you can do it very slowly and methodically. That's great, but the downside of that, of course, is that it costs much more in terms of resources, and potentially you may take much longer to unlock the clinical utility of a new intervention. So one of the, again, recurrent questions in medical innovation is the question of how aggressively to pursue an intervention. And a third big question is what to tell patients when they enroll in clinical investigations. Do you tell them that they are receiving something that's consistent with standard of care, that they can think of this as kind of a therapeutic process, or do you tell them that in fact they're basically guinea pigs, that they are being enrolled in research and that the primary benefit is largely to society. They may benefit by participating in the studies, but it's much more likely that they will be harmed than that they will benefit. So three really common questions. There are a lot of other questions out there, but these are three that come up again and again. Now, very difficult questions to answer, hotly debated in the ethics community. What I want to suggest is that knowing something about the structure of medical innovation can help us to think through how we might want to approach each of those different questions. So I started off by saying that every drug, surgery, et cetera, begins as a poison, and through the arduous work of clinical research is converted into a therapy. And what I want to suggest is that that process really consists of two core steps, two core processes. First, by themselves, drugs, surgeries, devices are basically benign. At best, they're they're either poisonous or at best they're benign. They don't do anything. Pills just sit in bottles on a shelf until researchers or until clinicians know what materials, practices, and beliefs to combine with that drug in order to unlock its clinical utility. So, for example, if you've got a drug, the drug doesn't do anything until you know what dose to give the patient. And I call that combination of materials, practices, and beliefs an intervention ensemble. So, for example, if we're talking about a cell therapy for the treatment of amyotrophic lateral sclerosis, in order for this cell therapy to be useful, you have to know which exact cells to deliver, you have to know what dose of cells to deliver, where to deliver them in the spinal cord, for example, what kind of immunosuppression regime to give patients to allow the cells to engraft, when to deliver the cells in the timing with respect to the disease course, et cetera. So a whole package of different kinds of information that have to be obtained in order to unlock the clinical utility of cell therapy for ALS. So that's the first step. The first step is identifying the key components of an intervention ensemble that have a plausible case of being therapeutic. And the second step is to take that intervention ensemble and to put it to randomized controlled trials. So that's the crux of what I view as the core structure of medical innovation. Now there are a couple points that I sort of need to unfold here a little bit. If you think back about the intervention ensemble, many of the different elements within an intervention ensemble can be thought of as dimensions. They take numeric values. So for example, dose, you can have different values for that dose. And for many of these different elements in an intervention ensemble, there is an optimum value and there is some kind of boundary, an upper boundary or a lower boundary on that dimension. So for example, you have an optimal dose, you have a lowest effective dose, and you might have the highest effective dose, a dose beyond which a drug begins to be intolerable, for example. Generally speaking, medicine likes to practice somewhere between that optimum and the lower bound. It's a fairly safe and a cheaper way to practice medicine. And what's true for dose is true for other variables as well. So timing, for example, when to intervene in a disease course, typically there is some kind of an optimum and there is some outer boundary beyond which an intervention will cease to be useful. And there may be an inner boundary as well for many different interventions. If you have a stroke drug, for example, a neuroprotective stroke drug, it may be useful 4 hours after a ischemic event, but it may cease to be useful if you deliver it 12 hours after a ischemic event. So a key task in early phase development in terms of identifying the key elements of an intervention ensemble is identifying the optima and lower boundaries on each of these different elements. And because there are multiple elements within an intervention ensemble, you can think of that process of early phase clinical development as akin to exploring a multidimensional landscape here just represented in 3 dimensions, where the goal is to identify that optimal value that's at the peak in terms of clinical utility, to explore the landscape in order to find where the intervention ensemble is optimized with respect to unlocking the clinical utility of an intervention. Once you have established that, of course, then the goal is to take those optimized conditions and to put them to randomized control trials. Okay, so just sort of an encapsulation of everything I've said really quickly. 2 key steps in intervention development. One of them is exploratory, exploring a landscape in order to identify the necessary and sufficient conditions of an intervention ensemble. And the second step is to take that intervention ensemble that has been more or less optimized, for which there is a high degree of confidence that the variables have been optimized, and to put that to some kind of rigorous test, typically a randomized control trial. Okay, so great, interesting abstract theory here. How can this inform the way we think about some of the ethical questions that I presented earlier? So let's take the first question of when do we randomize patients in clinical trials? So there's a lot at stake in this question. One of the issues that's at stake is that if we randomize patients before we have identified the necessary and sufficient optimized components of an intervention ensemble, potentially you spend a lot of resources, you expose a lot of patients to a subtherapeutic intervention ensemble, and you get very little knowledge. You still haven't really answered the question of whether or not an intervention has potential clinical utility. Now, anyone here who has been involved in clinical trials knows that every clinical trial, it's a fragile coalition. It's a coalition of the willing. You've got to keep the investigators on board. You've got to keep the referring physicians to referring their patients to them. You've got to keep regulators happy. Patients have to be continued to be accrued. And so this fragile coalition can easily fall apart. And typically you only get one shot with clinical trials, although there are lots of exceptions to this. But when you're dealing with novel innovation strategies, you get one at bat. And so you don't want to go too early before you've optimized your intervention ensemble elements, lest you end up failing to vindicate an intervention and delaying innovation in an area that may have substantial promise. The downside, of course, of waiting too long is that in an area like surgery, where you can actually put into clinical application intervention ensembles that have not yet been vindicated in randomized controlled trials, again, because of the absence of regulatory oversight in this realm, it means that potentially many patients are exposed to a suboptimal or even ineffective intervention ensemble in clinical practice, accruing not only risk for patients, but accruing costs for healthcare systems. So it's kind of a pedestrian observation. In a way, it's kind of an inevitable, but the question of when to randomize is when you have high degree of confidence that you have identified necessary and sufficient conditions for unlocking the clinical utility of a drug, that you have roughly established the optimal and lower boundary values on the different elements within an intervention ensemble. Okay. Next question is, how aggressively ought we to pursue clinical development? So this comes up again and again, particularly in an area like cell therapy. So for example, in Parkinson's disease, oftentimes people want to run trials and enroll patients with recent disease onset because the degenerative process is not so advanced that you can no longer actually recover function, or that you have something to protect in terms of further neurodegeneration. So oftentimes investigators and patients want to pursue recent disease onset trials, or they want to start dosing at what is believed to be the active dose. So that's one approach, what decision scientists might call a maximax approach. The idea of designing a trajectory of clinical translation along that line is that you're trying to maximize the prospect of maximal gains for a patient. The alternative approach, one that is often also defended, often by ethicists, is to use patients initially in studies who are refractory, who are at late stages, who have very little to gain from participation because their disease is already quite advanced, and or to begin at very low doses that are unlikely to be effective, but also that are unlikely to be harmful, an approach that a decision scientist might call a minimax approach. You're minimizing the prospect of the worst case scenarios. And so oftentimes debates in ethics review committees and in protocol development committees revolve around the question of which of these two approaches to use. How ought they to pace dosing, which patients ought to be eligible for participation in clinical trials. Now, oftentimes, patients and many clinicians make the argument that, of course, it ought to be up to the patient to make a personal choice about which risks they prefer. If a patient is willing to undertake extraordinary risks, it's up to the patient to make that choice. But of course, we know that research is primarily a public act. Research is primarily aimed at advancing public objectives, not private ends. It doesn't make them incompatible with advancing private ends, but the primary goal is to generate evidence in order to inform healthcare and to inform medical advance. And accordingly, it's those public objectives that really constrain the decision scenario, that constrain how we resolve those questions. And I want to suggest that using the minimax approach, the more kind of cautious approach, is one that better serves public objectives. And so I'll cash this out as follows. So I mentioned that the key goal of early stages of development is to identify roughly optimal conditions for putting an intervention to randomized controlled trials. And part of that is establishing the lower boundary for values within an intervention ensemble. If you use a minimax approach and you're starting off at a relatively low level of risk, patients who are refractory, low doses, et cetera, as you traverse that landscape, you are by necessity going to eventually cross a lower boundary and identify your optimum. So you'll deliver two key points that healthcare systems are going to need to know in order to use this intervention effectively. Again, the lower boundary and the optimum. Whereas if you use the max-max approach, in a best case scenario, on your first guess, you identify the exact right eligible patients for the study, and you have identified the optimal dose and all the other variables, and you've landed on top of the peak. That's great news. On the other hand, you know nothing else about the rest of the landscape, and one of the problems here is you never know whether there is a somewhat safer way of delivering the intervention, or whether, in fact, there might even be a more effective way of delivering the intervention. So you haven't really acquired the knowledge that healthcare systems need to know in order to unlock the clinical utility. Whereas the worst case scenario for the minimax approach that I described is that it takes a lot more steps, it takes a little bit more time to get up across that lower boundary and into the optimal area. So there is a cost, but the worst case scenario is less worse than it is or than it is in the best case. Now, in the worst case scenario, if you use a max-max approach, you overestimate the tolerability of the intervention, and you land up in an area of the landscape that is lethal or that has serious adverse events. Now, of course, that's tragic for the patient, but it's also harmful for the public objectives. I mentioned earlier that oftentimes in innovative arenas, there is a somewhat fragile coalition of the willing between, again, regulators, investigators, patients, et cetera. Oftentimes, when there's a lot of uncertainty, these kinds of catastrophic untoward events can trigger crises of confidence that set fields back substantially. We saw this certainly in gene transfer with the death of Jesse Gelsinger. Even in the fetal tissue transplant study that I mentioned earlier, there was substantial delay in terms of advancing cell therapy for fetal tissue in light of the outcomes, the adverse outcomes that occurred in those studies as well. So there are really good reasons, I think, in terms of the public objectives for pursuing a minimax approach. Namely, it helps us to identify the lower boundaries on intervention ensembles, and it helps to us to unfold the research trajectory in a way that sustains the confidence of some of the key actors that need to be collaborating in order to successfully execute a clinical translation program. Now the question of informed consent. What do we tell patients when they enroll in clinical studies? Do we tell them that this is a therapeutic opportunity, or do we tell them that this is an experiment, that they are unlikely to benefit from participation? Well, the answer is that it depends. And what I would suggest is that in those earlier stages of clinical development, it's best to present studies as experiments, and that's for two different reasons. The first reason is, as I said, drugs don't do anything when they're sitting on a shelf. They only do something when the researcher or the clinician knows what combination of beliefs and materials and practices to combine with that drug in order to unlock its clinical utility. So it's, in a way, it's kind of a category error to think of a drug as embodying therapeutic properties or power unless you have the knowledge of what to combine with it in order to unlock its clinical utility. So I think there's a logical reason to be reluctant to describe as therapeutic participation in early phase clinical trials. The second point is, remember I said that in order to successfully prosecute an early phase development program, you have to identify the lower boundaries on key intervention ensemble elements. That means that most of what's happening in early phase development is sampling within a landscape that's probably going to be below the optimal values on intervention ensemble, and many positions on the landscape that are going to be subtherapeutic. And that means that most patients that participate in early phase research are exposed to non-therapeutic interventions. I think once you have identified the approximately optimal elements within an intervention ensemble, there I think you have a compelling case to make to the patient that what they are receiving is competitive with standard of care. And so although they are participating in research, and there may be some ways that research antagonizes their own clinical ends, that essentially they are receiving care that is consistent or consonant with standard of care, that it's a therapeutic opportunity for them. Great. Okay, really abstract presentation, a lot about drugs, a little bit about cell therapy. What does this have to do with surgery? To what extent can we actually extend this approach to surgery? So first, I already mentioned that many of the interventions that I think about, cell therapies, involve complex interventions, involve surgical delivery, pharmacological co-interventions, a bunch of other procedures. And so the actual approach that I described to you here was really was something I developed mainly to address complex interventions. So I think it is applicable to certain areas of surgical innovation. So for example, cell therapy for ALS, I described the different elements in an intervention ensemble that can potentially take different values and that involve this landscape exploration. But what about pure surgeries, surgeries that don't involve delivery of a device or a drug that can be dosed, et cetera? Are those constituted by intervention ensembles? I'd suggest that they are, to a degree at least, that anytime you are conducting a surgery, you have to have diagnostic eligibility criteria for enrolling patients in the trial or for treating patients. You need to devise medical countermeasures, monitoring procedures, et cetera, that you're going to use and titrate according to the needs of patients or populations. Timing in terms of when you intervene is another element that has dimensional properties. And I'd say skill as well, operator skill in a surgery. Now, there's probably no optimal value of skill. I guess you probably can never be too skilled, although maybe it's a question of resource allocation in surgery. But there certainly is a lower boundary of skill that a surgeon needs to cross before you can begin to describe a surgery as having therapeutic properties, before you want to put a surgery into randomized controlled trials. So I would suggest that there are elements of surgery that really do resemble drugs and complex interventions, even when the surgeries don't involve delivery of intervention. So having said that, I think that I can extend this framework to surgery. I do acknowledge that there are some really important non-trivial limitations that fluster me and that kept me up last night as I was preparing this talk. And I would just, for transparency, want to reveal them to you if they haven't occurred to you already. One of the big issues with surgery is that because it is often irreversible, unlike a drug, which can be withdrawn, and because it is highly invasive, because the delivery itself is itself risky, oftentimes there can be compelling ethical reasons not to want to sample on either side of the boundary of different dimensions, or different elements in an intervention ensemble. So let's just take the issue of delivering fetal tissue into the basal ganglia of patients with Parkinson's disease. You don't want to underdose those patients in a study because, after all, there's about a 0.5% risk of death due to cerebral hemorrhage of the delivery process itself. And so that's a lot of risk to be putting a patient, to be exposing a patient to, just to kind of establish that lower boundary. Likewise, you don't want to overdose those patients. The brain is very delicately orchestrated. These patients are already fairly sick. You don't want to cause further derangement in their brain. You can't do anything, well, you can't do very much about that if you have injected too many cells and cause some kind of derangement. So I think there's a lot at stake, much more at stake morally in surgical development versus in drug development, in terms of not wanting to sample on the south side of the boundaries of intervention ensembles. And so that means that if you're going to develop a clinical development trajectory, you need some other approach to identifying exactly where those boundaries are. And I want to suggest two in particular. One is an intermediate approach that is combining the Minimax and the Maximax approach. So the idea is that there are some variables that you're working within a kind of a Maximax framework. So maybe you're delivering a dose that you believed is going to be effective, but there are other variables for which you are working along the Minimax approach. So maybe you're starting off with refractory patients at an active dose and working your way up from refractory patients to patients with early onset. So that's one way that kind of is a compromise between the two approaches. And the other approach, of course, is risk de-escalation. So you could try your best case scenario, work within what you think is optimal early on, and then subsequently perform randomized controlled trials or other kinds of investigations to see whether or not you can achieve the same outcomes with lower risk. However, I suspect my social science colleagues will agree with me, although of course they are, they never want to agree with me, but they probably would agree with me when I say that I think there are enormous social challenges in trying to unfold a clinical translation trajectory that risk de-escalates versus risk escalates. And I think a good illustration of this is the debates that surrounded the support study, which was a study looking at the level of oxygen saturation that's optimal for treating extremely preterm infants. This was a very, very controversial clinical trial in the United States, not a surgical study, but I think the ethical challenges here and the social challenges of pulling this off are a good illustration of just how hard it is to de-escalate an intervention, to risk de-escalate an intervention once it has been already put into clinical practice. So here the idea was that there was substantial uncertainty within the expert community about what the optimal levels of oxygen saturation should be for treating extremely premature infants. 90 to 95% oxygen saturation was believed to have a survival advantage, but it conferred risk of retinopathies causing blindness. And so there was some belief among some medical centers that you could go as low as 85 to 90% oxygen saturation levels, achieve the same kind of survival outcomes with less risk of triggering retinopathies in premature infants. And so throughout the United States, at least, many different medical centers had different oxygen saturation targets that they used. So sometime in the first decade of the last 10 years or so, a group of investigators led by a team in Alabama decided to conduct a randomized control trial testing which of the approaches was best. And what they expected to see was roughly equivalence. They actually expected, I think, to see that the lower levels could achieve the same survival advantage. But in fact, what they saw was that there was a substantial survival advantage for preterm infants that were receiving higher levels of oxygen saturation. Now the death, I always joke that in bioethics, anytime there are dead children, you got a big problem. So here you've got a bunch of dead, preterm, premature infants. Big controversy in the ethical community as well as in the policymaking community. There were lawsuits that followed from this, an investigation, et cetera, about whether or not patients had been adequately informed, whether the trial was properly conducted, et cetera. And I would suggest that when you try an approach to research that does exactly what these guys did, they try to risk de-escalate, these are exactly the kinds of conditions that tend to attract a huge amount of public controversy. And so it's much easier to front load the risk in medical innovation than it is to try to backload it like this. And so, so I'll just mention 3 key points, though, I want to sort of close with. These are sort of questions that I'm sort of stuck with trying to answer. So one question is, do surgeons, so I've developed kind of a framework for thinking about medical innovation. It'd be interesting for me to know whether surgeons actually think like this. Do they think in terms of trying to optimize different variables? Do they even think of surgeries as consisting of different elements that can be sort of orthogonally separated from each other and kind of explored in a dimensional space? I have no idea whether they do or not. And of course, even if they don't, whether they should is another interesting question. Another question I'm stuck with is the question of whether or not surgeons, this is my last slide, this is whether surgeons have accurate belief with respect to what those optimal variables, values are within intervention ensembles. So we know that surgeons are pretty bad at guessing whether or not a surgery is efficacious, at least as reflected by the fact that many sham-controlled studies end up not vindicating the intervention. But we don't know necessarily whether surgeons, and by the way, surgeons aren't any worse than other clinicians, it's just that we don't put surgeries to randomized controlled trials quite as much as we do drugs. But the question I'm asking is a slightly different one, which is whether they're pretty good at knowing where those optima are. Because again, you can't test those optima in randomized controlled trials, typically in early phase studies. And so that's another empirical question that I think is important to clarify in terms of the usefulness of this framework. And then finally, another sort of empirical question that I think is interesting to kind of speculate about is probably, I'm guessing, in surgery as in many other areas, there are different approaches people take to exploring this landscape. So some approaches use pure maximax, other approaches use pure minimax, and other approaches use some hybrid between them. And it'll be interesting actually to know, to quantify the efficiencies, the moral efficiencies of using these different kinds of approaches. And when I use the term moral efficiency, what I'm thinking of is the amount of information that is useful for healthcare systems as your output, and the number of patients that you need to put under the knife or expose to an unproven intervention in order to acquire that useful information. So it would be actually useful to know, to quantify the degree to which each of these different approaches pays dividends or has certain costs in terms of the moral efficiency of the research process. And I don't have any answers. I've given you reasons to think that I think the Minimax approach tends to have higher efficiencies, but I can't put numbers. So I'll stop there, and I'm happy to entertain questions.
So there is the first question there.
Thanks. Thank you for an excellent talk. There is a really excellent example of de-escalation, the de-escalation approach in surgery that occurred actually on both sides of the Atlantic. In North America, it was led by Bernie Fisher by the NSABP, and he pushed to a randomized clinical trial of total mastectomy versus lumpectomy with radiation therapy. And at the same time, we had, even with the results showing in at least 2 large studies showing identical survivals, we had people, sort of Halstedians, holdovers, saying in the public media, trying to whip up exactly the kind of media attention that you referred to, saying things like, over my dead body will I expose my patients to anything but what I considered to be optimal surgery. This went on for several months after the data was revealed, to the point where it was required that state legislators in the states pass laws obliging surgeons to expose their patients to the alternative data.
So that's great. Thank you. I'm sure there are lots of great examples, and I'd be interested to hear more. But in a way, I think, if I hear you correctly, although I don't know the particulars of the case, that you may be exactly sort of proving my point, which is that it can be incredibly difficult to enroll patients in those kinds of studies. Because who wants to go into, especially when you have advanced illness, you have a very serious disease, who wants to go into, medical intervention that might be able to achieve, the same outcome with a little bit less risk, but you don't know whether or not it's quite as efficacious. And so my impression is those trials typically have problems with enrollment. I mean, I know certainly a good example of this. This is not quite a good example of a risk de-escalation approach that I described, but it's kind of analogous, is the example of autologous bone marrow transplantation for high-dose chemotherapy in metastatic breast cancer. And there, I know that enrollment in that randomized control trial was very protracted, precisely because what oncologist wants to, enroll their patient in in standard of care when you have what looks like a very, very promising intervention on the basis of open-label studies. So I think it can be done. The risk escalation, the de-escalation approach can be done, but I think it's harder to build those stable coalitions of patients, referring physicians, and clinical investigators.
Yes, please.
Thank you. Thank you. That was an excellent presentation. You asked, what would surgeons think? Well, I think the best thing to ask a surgeon is whether that surgeon would want the operation himself. And if the surgeon says no, then you better think twice about whether the operation should be offered to anyone else. I think a good example of this is the first pneumonectomy, which was carried out by Everts Graham on a doctor. He had a cancer of the lung. He brought the doctor in, and this was shown in a video or in a movie that was taken of a two of them, which I saw. And he said to the doctor, he says, look, you have a cancer of the lung, you're going to die. You have a chance of surviving if I take out your lung. Nobody's ever done this before. And he said, fine, I'm going to go along with that. And then he was asked, how did you make that decision? I mean, that was a very difficult decision. He says, well, the first thing I did, he says, I went with my wife and we picked a plot. And then I went back and I told Dr. Graham that I was going to have the surgery. So one of the big issues for me has always been, sometimes if you're going to do studies, you have to have numbers. And very often operations become established before those numbers ever exist, right? So renal transplantation was established long before there were any numbers. external cardiac massage was established long before there were numbers, and if you go back to things like cholecystectomy, gastrectomy, these became sustainable operations long before there were numbers. But if you get back to Halsted, sometimes there's misinformation amongst physicians as well. And if anyone had looked into Halsted's numbers, perhaps they would not have decided that total mastectomy was an operation of choice. So when Bloodgood, who was Halsted's first resident, the second resident was Harvey Cushing, who you all know, but you may not know Bloodgood. There is a Bloodgood cyst and things of that sort. Bloodgood went back and reviewed Halsted's numbers and Welch's numbers and found that 15% of the patients that Halsted operated on and did mastectomies on never had cancer at all. And that certainly would have changed his outcomes.
Oh, that's really, really interesting. So, you know, I'm really interested in this, you know, so I should disclose, my wife's father is a surgeon. So I once asked him what he thought was the most important trait in being an effective surgeon, and he said confidence, which didn't surprise me too much. I've always wondered, you know, it's an interesting question, how, you know, I think I do a lot of work looking at confidence and the psychology of confidence, and you know, you mentioned that you know, the best way to find out whether a surgery is you know, is useful is to ask a surgeon whether they would want to, you know, go under the knife themselves for it. But actually, it's an interesting question whether or not surgeons are able to titrate or calibrate their confidence in a way that's accurate, whether they are surgeons overconfident or they I doubt they're underconfident, but are they overconfident or they get it just right? I mean, you can be confident and get it exactly right, and to me, it's a really interesting empirical question about how accurately surgeons are able to titrate their confidence. And I think it's really relevant for thinking about what I'm describing, because again, if you're talking about what these optimal values are, you want surgeons to know just how uncertain they are about those values. But
when we discovered something in common, my wife's father was also a surgeon. Is there any other question? Then maybe very quickly, you mentioned that one of the. Oh, sorry.
Yes,
No,
yes,
go on.
You mentioned this.
thank you. That's no, I'm just joking.
You mentioned the support trial, and I was thinking of it before you brought it up, but in a slightly different context, because I wondered when you made the distinction between max and max-min, you talked a little bit about the ability to disclose the trial as being more therapeutic or more simply experimental, and the thing that popped in my head was the support trial, which looks a little bit like one of your max trials. They're trying to hit close to that optimal peak, and they were called out because they had been insufficiently thorough about disclosing some of the experimental qualities of it. I wondered if your observations about how these things get set up help with unpacking that pretty thorny dilemma.
Yeah, so I would not think of the support study as sort of the max and max-min. That's not useful for thinking about the support, because in a sense they were taking two interventions that were believed to be comparable in terms of their efficacy and putting them to head-to-head studies. And so there wasn't this idea of kind of an iterative approach where you are, you know, testing something, you know, you can sort of just, you know, you can't quantify, you know, max and minimax are really useful decision tools when you can't really quantify the level of risk around it. Whereas I think with those two interventions, you know, you can begin to sort of quantify the risk when you initiate those clinical trials. So I think that's not, the max-min and max approach, probably not that useful for thinking about how that study was set up.
More like for cancer trials, right? I mean, it's a cancer chemotherapy model in some way.
Yeah, I mean, the way I'm thinking about it more is in the context of either in a phase 1 clinical trial where you're doing dose escalation, or where you have a series of studies. So you've got a phase 1, a phase 2 study, perhaps another phase 2 study, and then you've got a phase 3. And the decisions that you make as you advance from one cohort or one trial to the next, as opposed to necessarily within one study that's actually a fairly rigid study, right, that's randomizing patients. I think that was a really interesting, it was a really, really fascinating episode, and it really shows, I think, some of the pearls and challenges of doing comparative efficacy studies. I mean, they were both standard of care at many medical centers. You know.
I couldn't get you to come down on one side or the other then.
On support,
On support,
I
yeah.
can, well,
Okay.
so I generally think, would generally side on those who were defending that study. It seemed to me like a good study. There may have been some issues with the informed consent. There were some details. I remember there was something about the blinding of the monitors for oxygen saturation. There were a couple little things, but the basic idea of taking two interventions that are already standard of care and testing them in a randomized controlled trial, and viewing both arms as being consistent with standard of care is to me a sound one. I think we need more of that kind of research.
Well, we have to stop here because it's
Sure.
time for the next speaker.
Good.